Continuing our discussion on diseases of the lower GI tract, today we are focusing on inflammatory bowel disease, or IBD. IBD refers to an autoimmune chronic inflammation of the GI tract. The term IBD can mean one of the two conditions here, ulcerative colitis, or UC, and Crohn's disease. Historically, IBD has had a higher incidence in the Northern Hemisphere, but in recent years, data indicates that the global incidence of the disease is increasing globally. Here in this figure, we see the red has the highest incidence, yellow intermediate, blue lowest, and gray uncharted, and this is from data collected in 2015. The exact cause of IBD is not known. It seems that people who develop IBD have certain genetic predispositions, and when these individuals are exposed to certain factors, whether it is environmental or other clinical conditions, it causes an improper immune response in their own body. So this is an autoimmune response. These factors that trigger it can include smoking, infection, dietary factors, and certain changes in the small intestine. When these genetically predisposed individuals are exposed to those triggers, their body launches an autoimmune response. This causes the release of the pro-inflammatory cytokines, and eventually it will lead to the destruction of the mucosa in the GI tract. So here we see the type of damage that IBD can cause. So this is showing the histology, a picture using an endoscope, and the figure drawn out here. So we see the normal colon, the colon in Crohn's disease, and the colon in ulcerative colitis, or UC. If we look at the normal colon, we see in this microscopic view different structures of the crypt cells here in the mucosal layer, and they are providing all this surface area. So this is what a healthy colon would look like under the microscope. Here in the endoscope, we see that the color is pink and that the surface is relatively smooth. Now, we know that the surface of the colon is not supposed to be super flat or smooth. For example, it's not like a water hose. But we also do not have the villi that we have in the small intestine. However, we can see in the diagram here some of these structures that are inside the colon, these shelf-like intraluminal projections. And outside here, we see these pouches or sections called the haustra. In Crohn's disease, over here, we see the difference in mucosa. So it's pretty unrecognizable compared to what it looks like in a normal colon. The mucosa has been destroyed by the immune response in the case of the Crohn's disease. And if we look at the endoscope picture, we can see that the color has changed, and also notice these dots or bumps or knots that we can see here in the lining of the colon tissue. And in the diagram here, we can see that those knots that we saw up here are referred to as cobblestoning, which is an appropriate description of the appearance. In addition, the wall of the colon here has thickened. So there's a big difference compared to the normal colon over here. In addition, the thickening of the wall results in the narrowing of the lumen. So if we look at how big the space is over here for the normal lumen, and then come over here, we can see that the diameter is much smaller in the colon affected by Crohn's disease. And we can imagine what symptoms our patients with a narrowed lumen would be experiencing. The changes also affect the outside of the colon. So here we have the normal band of fat, and then in Crohn's disease, we have the enlarged fat wrapping. So that strap here is much wider compared to the thin one in the normal colon. Another thing that can occur in Crohn's disease is fissures. So although the wall has been thickened, we can still have a perforation or a leak to the outside of the colon, and this would require surgical repair. And then next, when we go over to the ulcerative colitis, we can definitely confirm the pathology in this microscopic view. We can see that all of the mucosa here has been destroyed. It also appears very different from our normal colon. And if we observe with the endoscope, both the color and the shape has changed. So going to the diagram, we see that the normal haustra, those sections or pouching here, are no longer here. We have lost the haustra. The outside is completely smooth. And remember, the mucosa has been destroyed, so the lining also looks quite a bit different from the normal colon and the colon in Crohn's disease. We can see a pattern here with the ulcerations, and this is where the areas have been destroyed. And then there's also areas of the surviving mucosa, and we can also visualize those changes, the mixture here in the endoscope picture. So there are two types of IBD, and both can cause change in the GI tract as compared to the normal colon, although we can see that the damage done between the two IBDs are different. So here we can compare the two different types of IBD, the UC and Crohn's disease. UC primarily affects the colon and the rectum sections of the GI tract, whereas in Crohn's disease, it can occur in any portion of the GI tract. In terms of damage, UC causes ulcerations to the mucosa, and it leads to a thin, ulcerated colon, what is referred to as the toxic megacolon. Whereas in Crohn's disease, as we previously mentioned, here we see a thickening wall in the colon, but there also may be fistula. We may have strictures and obstruction, and we may have the perforation of the wall of the colon, and these would all be considered severe complications. Now remember that there are the 4 layers of the wall of the GI tract, and in UC we usually see damage to the first 2 layers starting from the lumen side. So that would be damage to the mucosa and submucosa. In Crohn's disease, the damage could affect all of the layers. And remember that we have the fistula, and that could penetrate the whole wall and cause leakage into the intestinal contents. Also, UC generally affects one section of the GI tract at a time, whereas in Crohn's disease, we could have a skipping pattern affecting multiple sections of the GI tract simultaneously. The main symptoms of IBD include abdominal pain and bloody diarrhea. So remember, in both cases, the mucosa is destroyed. Therefore, it would be understandable that there may be blood in the loose stool. In addition, people may experience tenesmus, meaning the urgent feeling of the need to defecate, even if they have just done so. It also involves having to strain to produce only a small amount of stool. So here, the control for defecation is diminished for patients with this disease. In severe cases, patients may have a fever, they may experience increased heart rate, tachycardia, and the loose stool of diarrhea may have pus and mucus in it. These are all related to the destruction of the tissue. In lab work, it's very common to see elevated inflammation markers in these patients. CRP is a well-known, commonly used inflammatory marker. And ESR, erythrocyte sedimentation rate, here we're looking at red blood cells. ESR is a marker commonly checked in autoimmune diseases, for example, in renal disease, or in lupus, or in this case, IBD. And the increase in ESR usually indicates there is some immune dysfunction going on. So when abnormal proteins are found in the blood, these are typically due to inflammation or infection. They cause the red blood cells to clump together and sink more quickly, and this results in a high ESR value. Of course, white blood cell count is elevated, and also weight loss is very common, especially in people who have frequent flares of the condition. So if we think about all that's going on with the GI tract and the damage that's being done, it's understandable that people would be experiencing weight loss. To treat IBD, we can use specific antibiotics. They play a role for the maintenance of remission and prevention of postoperative recurrence, and also in treating septic complications that may occur. And because it is an autoimmune disease, we can also use medications that either suppress the immune response or that better modulate the immune response. Of course, we know that medications can have side effects, and specifically for these, we have depressed the immune response, and therefore our resistance to real pathogen infections will be compromised as well. Biologic therapies are medications made from antibodies grown in a lab, and they stop certain proteins in the body from causing inflammation. This is a more targeted approach than some of the other medications. And there is also surgery. For certain cases, parts of the GI tract may have to be surgically removed, or if there's a fistula, or if one causes an obstruction, then we may have to use surgery to relieve the obstruction. Also, malnutrition is not uncommon, and because there is altered GI function in IBD, we will often have to prescribe nutrition support, either enteral or parenteral nutrition, or sometimes both. So here we see the treatment pyramid for treating IBD, and we notice that as the cases get more severe, we're going to use the step-up approach, and also note that nutritional support is provided along this entire continuum here. The nutrition assessment must be comprehensive. Based on what we have covered so far, there is unknown etiology, people may have a genetic predisposition, and there are different triggers of the autoimmune response. Therefore, we need to be checking personal history, family history, dietary preferences, and lifestyle factors, such as if they smoke. In addition, if it is a reoccurring case, we should know what was previously done that was effective and what is new in the most recent flare. All of this will be very helpful for us to reach a current nutrition diagnosis. As we mentioned, it is common for people with IBD to be malnourished, so it's no surprise that we may have a lot of inadequate intake problems within the intake domain. Also, common problems in IBD are impaired nutrient utilization, altered GI function, and food-medication interaction. All of these are associated with the pathophysiology and treatment of this condition. IBD is a chronic autoimmune disease, but the condition doesn't always have the same level of severity going on 24 hours every day. There are periods of exacerbation and also remission periods. Obviously, the exacerbation period is more severe. There will be more discomfort or pain, and often it requires medical attention. When people are experiencing a flare, whenever possible, we want to use enteral nutrition if the oral diet is not tolerated. Study after study indicate that as long as the patient can tolerate tube feeding, it should be chosen over parenteral nutrition. When Crohn's disease is found in children, studies indicate that enteral nutrition is better than corticosteroid hormone treatments. We know these hormones are very potent anti-inflammatory agents, therefore they can quickly and temporarily relieve symptoms. However, there are consequences of using them. For example, it will induce fat deposition in certain parts of the body and also increase blood sugar and blood cholesterol. And for all patients, even especially children, we want to avoid these side effects as much as possible. For adults with exacerbation, if use of medication is not an option, we will have to use additional nutrition as needed. So again, enteral nutrition should be the first thing to be considered as long as the patient's gut is working. And we do not want to prescribe PN with bowel rest universally, as it is a cookie-cutter approach. Now, some patients may need it, especially those who have multiple severe flares in the past and have had several parts of the bowel surgically removed. They may end up having what is called short bowel syndrome, or SBS. In this case, due to the short length of the remaining intestine, there is not enough for either oral intake or tube feeding to provide adequate nutrients because the remaining bowel is not able to absorb enough nutrients efficiently. So in this case, we would use parenteral nutrition. Also, for patients who have just undergone an operation, during the acute recovery process, we want to use PN to bring them through that phase. In the recovery process, there are certain adaptations that occur in the GI tract. Then we can wean them off the PN, and we may start with tube feeding, then eventually they will hopefully be able to resume PO intake. When patients are going through exacerbation, we consider that acute inflammation a stress factor. It is significantly increasing the energy requirements, so this must be considered. When patients are going through exacerbation, we consider that inflammation a stress factor. It significantly increases the energy requirements, so this must be considered. Of course, if we have indirect telemetry, we would want to use that to tell us how much energy the patient needs at that moment. Patients with weight loss and inflammation or infection, all of those stress factors, that would obviously call for more energy, especially in infants and children. If we remember, infants and children require more energy per kilogram of body weight than adults because they are growing fast. We need to provide a lot more energy per kilogram of body weight. With IBD, infants could receive 120 kilocalories per kilogram, and children could receive 80 kilocalories per kilogram. According to Aspen guidelines, patients with exacerbation of IBD have increased protein needs. We could provide 1 to 1.5 grams per kilogram body weight for adults, and even higher at 2 to 2.5 grams per kilogram for infants and children. And of course, this is a lot higher than the 0.8 we usually use for adults. Overall, a low residue, lactose-free diet will help. A low residue diet is designed to produce fewer, smaller bowel movements each day. It is low in fiber and usually restricts foods that increase bowel activity like fruit juices and milk products. Also, it may be necessary that we adjust the dietary fat content because sometimes due to the conditions and the impaired GI function, we may see fatty stools or steatorrhea. So looking at this word here, we have steato, which is the prefix for fat, and then rhea, meaning flow, as in diarrhea, with the increased flow of stools. So here for this term, it's meaning that we have fat appearing in the stools. Small frequent meals may also help. And we need to be paying special attention to see if the patients are at risk or already have micronutrient deficiencies. Because of the nature of the disease, we need to be concerned with several micronutrients. For example, we see here zinc, calcium, magnesium, and iron, as well as vitamins B12 and D. All of these are at high risk to become deficient in IBD patients with an acute flare. So when things calm down in remission, we want to maximize energy and protein intake. At this point, the patient is not suffering as much, so we really want to provide them with as much nutrition as we can and also regain the weight that was lost during the flare. We also want to incorporate physical activity as tolerated. We should help the patient try to normalize their dietary pattern as well as promote foods high in antioxidants and omega-3 fatty acids. So these two groups of nutrients have been shown to have anti-inflammatory properties. And since the nature of the two IBDs are chronic inflammation as part of the autoimmune response, we want to provide these anti-inflammatory nutrients to help manage the condition. Also, we want to limit foods that are high in oxalate because high oxalate foods in IBD, they can increase the risk for stones in the renal system for these patients. And when we study renal diseases, we will see that this is something that is also applied to people with kidney stones with or without IBD. And due to the fact that the colon is affected, probiotics and prebiotics are very useful to reinstate the normal gut bacteria profile in the colon.